Hi everyone, welcome to the NIHR Insights Engagement Programme for the West Midlands. The webinar today is presented by Birmingham City University. The webinar is Knowledge to Care, and the aims are to understand the key approaches to ensure uptake of evidence in practice. So I'll now hand over to our presenters to introduce themselves. Thank you.
Thanks, Alicia. Hello, everybody. Welcome. My name's Judith Dyson. I'm a professor in implementation science. Serena.
Hi everyone, I'm Serena Raju. I'm a research assistant.
Hi, I'm Hannah Harvey. I'm also a research assistant.
Thanks, Hannah and Serena. So the thing that we three have got in common is all of our work is about getting evidence into practice. I'm talking about research, healthcare evidence into healthcare practice. There are many problems with that, and there are many techniques that we might use. So let's just jump right in and let's give you a few statistics. So believe it or not, it takes around 17 years to get research into healthcare practice. That's an awfully long time. That's across all different types of practice and all different types of evidence. Generally, we're a little bit better at getting evidence about medicines into practice, and largely that's because farmers got a lot of muscle and a lot of money and can put a lot of effort into getting their medicines adopted quicker than perhaps other practices. Even when evidence is assumed to have been adopted into practice, around 30 to 40% of patients don't receive care according to best practice guidelines, and you can see here between 20 and 25 receive care that is not needed. Failure to implement suggests that we're wasting an awful lot of money. Around 85% of healthcare research is wasted at a global cost of around $200 billion. So why is all this happening then? And let me just pause for a minute and say, feel free to join in the chat, type anything you like, put your cameras on, shout out, do anything you like, stop us at any time. Okay, so there is a history of Islagiat. So Islagiat stands for it seemed like a good idea at the time. This was a term coined by Martin Eccles. So basically, when practitioners are failing to deliver practice according to best practice guidelines, somebody in healthcare practice thinks, I know, we'll try and improve things by doing this, based on no theory necessarily, based on a little bit of common sense somewhere, sometimes, but oftentimes based on this assumption that if people know what they are supposed to do, they will do it. So often when evidence is not implemented into practice, the knee-jerk reaction from healthcare practitioners is send them on training, let's go on training, let's put some training on, let's send a guideline, and let's have a workshop. All of these techniques are based on information which addresses knowledge deficits, but it doesn't necessarily change clinical practice behaviour. We know that knowledge, information, is a necessary prerequisite to change in practice, but on its own, it's actually not that effective. Now, there are these 5 umbrella terms about how, and these are the main approaches to how we get evidence into practice. And me and Hannah and Serena and others have done some work on this, looking at the differences. We've held workshop with people who call themselves implementation scientists like me and all of these other things, and said, what do you do? What do you do? How do you do it? What are the differences? Now, what we've found is that we need to use some of the techniques from each of these as complementary approaches to get evidence into practice and keep it into practice. Often the techniques used to get new evidence into practice are the same techniques as would use to keep evidence in practice or improve practice. So we thought the best way of demonstrating this was to take each of these approaches, just projects that we have done over the last few years, and explain to you very briefly what we did. So we're going to spend less than 9 minutes on each of these, and then we're just going to spend 2 minutes closing this talk. So we're going to start with implementation science. So this is our definition, and at the bottom there, you can see that we've got a reference. This is actually in press. It's not out there yet, but it will be in the next couple of months. So you'll be able to find this very soon. So this is an accumulation of everybody's views in the literature and otherwise. So implementation science is the study of the adoption of new evidence into routine practice. So we're getting new evidence into practice. So the example I'm going to offer you here is what happens if we don't use strategies and techniques to get evidence into practice, to implement new things into practice. So this is a study that involved this cushion. It's a lifting cushion. So the idea is that it deflates and you roll it under somebody who has fallen and slowly inflate it, and it helps them up. We implemented this into 20 care homes in the whole of across Birmingham, basically. And the problem that faced us was if somebody falls in a care home historically, they don't help them up at all because they're worried that they might come to harm. They might have a broken bone. It might do more harm than good. Care homes sometimes have nurses. They sometimes don't have nurses. There's not always a qualified member of staff. And care home owners are worried about litigation. So what they do is they call an ambulance. And as many of you on this call will know, an ambulance can take a very long time, and some older people have fallen and they've been waiting for like 14 hours plus. So there's a real quality issue here for people. So alongside this kit that we put into, I said 20, but 18 to left the study before we finished, 18 care homes, was this app. I'm showing you here, this I Stumble app. And here's one page of some questions. And if it was yes to all of this, then the carer or nurse would click yes. There'd be another page, more questions. And at the end of clicking yes or no, the app would say it's safe to help this person up, or it's not safe, call an ambulance. So the idea was carers would use this app to assess the fallen person. And if it was safe to do so, they'd use this cushion to help somebody up. Now, you know that we sometimes have hoists, but they don't really fit in care homes a lot of the time. The environment's not sufficient. These great big hoists. It's safe for both the care home residents plus the staff to be lifting without some means of support. So that was the idea here. I'm going to show you the results in just a moment or two. When we were asked to do this piece of work, and it was a local piece of work, we said, how are you going to get people to do it? And the people that wanted this to happen said, we're going to send 2 members of each care home on central training. We'll show them how to use it. Then they will go back to the care home and they will tell everybody else. Everyone will sign to say they've been told how to do it, and then they'll be allowed to do it. We'll provide them with the cushion. And we said that's not likely to work because sending someone on a workshop's not enough of an implementation strategy. It's too weak. It's not going to get people making this quite significant change in practice. They didn't want us to do anything else, but we did persuade them that we could ask practitioners about their experiences of using this. So we did some qualitative work as well as looking at the levels of adoption. And we asked people about the barriers and facilitators, those things that help and hinder use of this piece of kit. So on this slide then, I'm showing you a run chart or a statistical process chart, pre and post intervention. So we collected data. These are falls data, which of course we weren't seeking to influence. So we'd expect them to be similar before and after. These are methods of lifting, and you can see that there were just staff only assists. That was the main means of helping people up when they did fall, which isn't really that desirable. And then here we've got ambulance calls in red. And here you can see we've got how many times the cushion was used in these little green bars here. So was this implemented or wasn't it implemented? there would be some cases where an ambulance would be required. So you'd expect some ambulances to be called. There was a hope that staff would use support to lift. And if you actually look at the mean before and after, that did drop a little bit. And then some of these other calling an ambulance, there was no statistical difference pre and post, and you can see that that's more or less level just by eye. And these other things were things like hoist and people getting up on their own, no difference at all. So what I'm going to tell you is that the cushion across 18 care homes was used only 18 times. Sorry, I've got that wrong. Only 32 times across these 18 care homes in this period of time. These are weeks, 1 to 15, 1 to 15 before. And there were 567 opportunities to use the cushion. So only 32 out of 567 opportunities. We didn't do an economic evaluation, but we just did some basic sums. So the cost of an ambulance being called out where somebody is just assisted to get up, which is what happens most of the time, nearly all of the time, cost £224 per call. Given that the cost of the cushion was spent £19,000 on the cushion across all of these 18 care homes, if you divide that by 32 uses, that works out at £498 per use. The cost of the cushion ended up being double what an ambulance would have costed. And for 32 people, it might have resulted in them not lying there for as long as they would have before. And this is the issue if you don't use implementation techniques, if you just send somebody on training. What people told us, believe it or not, because we asked them, and this is what you do, this is an implementation technique, ask somebody what stops them, solve the problem. They weren't allowed to have devices on the shop floor. So they didn't have this to assess whether somebody was safe to rise. It was against policy and nobody thought to change that. And there were other things like people who were not quite so proficient with older people with dementia were scared to use it. They thought people with dementia would find it frightening too. Whereas those that were more proficient with people with dementia, they trained using the cushion in front of them, so people were used to it. And so on and so forth. There were many other things that I don't have time to tell you about now. But the big learning point here is if you're trying to implement new evidence into practice and you're not asking the question, what's going to help, what's going to hinder, and then tailor strategies according to those things, you're going to end up with 32 out of 567, which is suboptimal. Okay. So moving on to the next thing then, and I'm talking about co-working. I've just realised I'm telling you what happens if we don't do it. I think Serena and Hannah have got nice things where they tell you the wonderful things that happen if we do it. So co-working then, there's lots of words that are used: co-design, co-production, co-creation, participatory methods. But basically what we're looking for when we're trying to get evidence into practice, we want the service users and providers to basically co-design the strategies to get evidence into practice, because they're the ones that are going to deliver it and receive it. And without doing that, it all goes wrong. So on this one slide, I'm going to tell you the story of how it all went wrong here. And actually, can I just say, most of my projects are really successful. I've just realised that I'm starting off with ones that are not. But this was a hand hygiene monitor and prompt device. This was going back to the references 2017. I think we did the work at 2015-ish. And it was me and this guy called Morris, who at the time worked in Donny. And I think he's now in NLAG as the chief nurse. He was Director of Infection Prevention and Control at the time. So a hand hygiene monitoring and prompt device is, for those that don't know, staff basically wear a badge, and on the ceiling, sensors are placed as a member of staff would walk into a bed space. And as the member of staff goes under that sensor, the badge is triggered. If the member, and the expectation is, the member of staff will clean their hands and deactivate the badge within a minute or 3 minutes or something. And if they don't, then it goes bright red. And if there's still dirt after another short period of time, then it starts beeping. So how it was deactivated, when staff gelled the hands, they could put their hand to the badge and it would automatically deactivate. If they were washing the hands with soap and water, there were also sensors above the sink. And if a staff member was stood there for, I think it might have been 1.5 to 2 minutes, that was a proxy for they were cleaning the hands. They could have been sat there having a chat or stood having a chat, but the expectation was they were probably there to clean the hands. So at this time, this was, as you can see, around 2015, we'd got over that big peak of MRSA and Clostridium difficile. Things were settling down, but their hand hygiene audits were coming up at about 70%. So we know hand hygiene audits are an inflated number because of the Hawthorne effect, because we're watching people, so they engage in desirable behaviours more. So if that was coming out at 70%, chances were that hand hygiene was probably closer to 50, which is a problem, of course. Anyway, these blue bars then, this is hand hygiene as observed in routine hand hygiene audits by the Infection Prevention and Control team. What I'm going to tell you here is this is gold standard, observing hand hygiene. So that's the most accurate measure. And you can see, that on average, probably, we're looking at 60% adoption. We've got some higher ones, we've got some lower ones. These orange lines then, these bars, are when we had these were what was measured using the device during the duration of the device. And then this dotted line here is gel use. And what you can see here is, according to these orange bars, we're not far off 100%, are we? Each and every one, it's nearly at 100%. But look, hand hygiene, according to observations, it was a bit higher than before, but it definitely wasn't 100% very often, maybe in those cases, but not usually. So why the difference? Because actually, well, anyway, why the difference? I'm going to tell you because I haven't got time for you to answer me. The difference was staff hated this device. They felt patronised. They felt not trusted. One of the nursing assistants said to me what she used to do, she used to gel her hands and she'd go around helping everybody else out by deactivating their badges. A charge nurse told me that when they were doing the meds round, they basically put the device on top of the trolley so that the badge wasn't being activated and deactivated every time it went in the room. There were problems with this device. If you're taking in, say, bedpan as a bad example, you go into the sluice room, you get on up, you put your gloves on, you've got your bedpan, you walk to the door of the room, you're not going to take everything off, wash your hands again, put everything back on as you enter the room. So there was problems with this badge, quite rightly. They cheated. In healthcare, we call that gaming the system, don't we? They gamed it. And we know a lot about that with the cloth and the tick boxes and so on. So this is what happens if we don't co-create and people don't adopt the improvement or implementation strategies we're trying to use. So when we're trying to get evidence into practice, we work with, in this case, practitioners. I'm just going to pause here for a minute before I move on, because I did say practitioners and patients, and yes, we would co-design with patients as well. In this case, we didn't do either. Years ago, around the time of high levels of superbugs, MRSA and Clostridium difficile, there was a national campaign called Clean Your Hands. And in that campaign, staff wore badges, and the badge said, ask me to clean my hands. The patient was supposed to prompt them. The patients hated that. They'd not been involved in that either. It's a judgment as to who you involve. I did a piece of work recently in operating theatres about the World Health Organization patient safety checklist. No patient would ever be aware that that is happening. And I decided it was inappropriate to involve patients. I just spoke to staff. But most of the time we talked to both staff and patients. Okay, I'm going to hand over to Serena for technique number 3.
Thank you, Judith. So knowledge mobilisation, what is that? A really good definition is by Cowdell and colleagues. It's about studying and sharing usable knowledge across communities to catalyse change. Another great way of thinking about it is it's about moving knowledge to where it can be most useful. So there's some great kind of theoretical papers by Vicky Ward and colleagues. And also it's about that knowledge can be about include practical experience, technical knowledge, and research evidence. So it's not just about the research evidence, it's giving kind of equal importance to the practical experience and technical knowledge. So my PhD research study was about addressing the evidence to practice gap in relation to weight gain during pregnancy. And I focused in on midwives' consultations and how they can be best supported to advise South Asian women. And the reason I decided to focus on South Asian women was because there's evidence around the risks of excessive weight gain during pregnancy, that they're at a significantly greater risk of gestational diabetes. And also that following a diagnosis of gestational diabetes, they're significantly more likely to develop some long-term health conditions. So the underpinning theory of the study was mind lines. So mind lines are essentially collectively reinforced, internalized tacit guidelines on which clinical decisions are made. And they come from a variety of sources, as you can see from this diagram by Gabay and Lemay. So they can come from the media, textbooks, what other people say, but as well as the research evidence. And that just made complete sense to me. And the important point to note is that they can maintain both helpful and unhelpful practice. And they can provide as well a lens for understanding how knowledge in relation to weight gain during pregnancy is shared amongst pregnant women and midwives. So I use mind lines as a foundation for enhancing midwives' mind lines in relation to weight gain during pregnancy. So it was a 3-stage study. It started off with 3 literature reviews. The next phase was interviews with South Asian women and midwives, and it was women from a variety of ethnic backgrounds, and including South Asian women. And as you can see from this diagram here, there's quite a big connection between women and midwives' mind lines. So we've got some color coding here. In the muted red were barriers to advising women or women's health, weight management during pregnancy. In the muted yellow, we've got kind of dual barriers and facilitators, and in green we've got facilitators. So there was some connections as well. So you can see environmental influences on women's mind lines that actually influence midwives' empathy for women, which was a facilitator for midwives' practice. Midwives did have some conflicting perceptions of obesity, so some of them touched on kind of individualistic views of obesity. So that is kind of seeing it as women's responsibility, for personal responsibility for weight management, whereas some acknowledge that actually there's a variety of influences on weight management, as well as kind of individual factors. It's things that were outside of their control, like the kind of built environment and prevalence of fast food outlets. And a lot of midwives talked about lack of time and resources. So what I then did was carry out some co-design workshops, asked midwives and women kind of what they thought about how midwives' mind lines can be enhanced. And they came up with some interesting ideas. And in the end, we decided that a brief talk on the topic, or a kind of at the annual midwifery training day, will be the best technique. But as part of that, I kind of designed some postcards which integrated some of the suggestions across the reviews and interviews and workshops. And you can see here, this is a postcard. You can scan the QR code and that'll take you to the online version of the postcard. And this acronym, Make It Count for Women, actually summarizes women and midwives' views across the workshops and interviews. So, for example, motivation, remember women's motivation to protect their health. And then there's an actual quote from a South Asian mother, and so on. And after the workshops, I carried out some individual interviews with midwives to kind of determine the acceptability of the postcards, and also a video that I designed as well. And overall, they regarded the postcards and video as generally acceptable to midwives in practice. And I'm now carrying out a pilot study to actually evaluate the acceptability of the postcards and video for midwives and wider groups of South Asian women in order to develop them further as well, and hopefully roll them out within an NHS trust at some point. So I'm going to hand you over to Judith.
Back to me then. So this is the fourth kind of approach out of 5, improvement science. And I'm just going to reiterate again that often the techniques for knowledge mobilisation, implementation and improvement are all really similar. So improvements science, studying and enhancing the adoption of evidence into practice. So for improvement, we're all often talking about established evidence that's in practice, but not very well embedded into practice, not necessarily adopted, even if the evidence supporting it was donkeys years ago, just as with hand hygiene, for example. So I've just got this one slide to explain this study. So this was about people with asthma and it was about practitioners in general practice prescribing according to guidelines. And the prescribing guidelines are SABA-free MART. So in the olden days, people used to have a preventer inhaler that was brown and a reliever inhaler, SABA, based on salbutamol, that relieved symptoms when they happened. And people were told to take the brown one all the time, 3 times a day or something. And then if they had an exacerbation, breathlessness or wheeziness, then to have the blue one to relieve. But as time passed, we became aware that the blue ones caused a lot of damage and they actually worsened asthma over a time if people were using a lot of them. And also we realised that what people naturally do is they forget about their asthma when they're symptom free. So they forget about taking the preventer inhaler. They wait until they get symptoms, then they have the blue inhaler. So there's this vicious cycle of people having more blue, more of this SABA than they should, and not taking the reliever inhaler. There's now a medicine that does both. It both relieves and prevents, and the reliever ingredient works just as fast to relieve symptoms, but it's not as harmful, and that's called MART. So we were asking people about making this change, improving practice. Adoption's really low, and these were some of the things they told us. And just like with Serena, the barriers are in this orange colour and the facilitators in green. And despite this being a problem for very many years, this prescribing problem, we identified things that had not been identified previously. And I'm just going to point out a few. So this one, MART stands for maintenance and reliever therapy. So both, it maintains and it relieves. So this one here, psychological dependence. We spoke to patients, we spoke to healthcare nurses, doctors, pharmacists, the whole range of different people. Patients realised this was bad for them, this blue inhaler. So this is a psychological dependence to the SABA, the blue one, the reliever. They knew it was bad for them, but they've been told for years and years by senior doctors, from childhood often, never leave this at home, always have this with you, have one in your pocket, have one in your car, have one here, make sure you've always got this in case you have an exacerbation. After years and years of that being kind of told to them over and over again, leaving it, not having that inhaler was a real struggle. The practice to the point where, despite knowing it was bad for them, and despite knowing that this MART, this combination inhaler, was just as good, they told me they'd do things like they'd take if they had an older relative with COPD, they'd take their inhalers. They'd go to Spain where you can buy 12 SABAs at a time. They'd find a practitioner that was more willing than other practitioners, and they'd persuade them. There was a lot of that going on, and practitioners found it really hard to resist. They felt sorry for these people. Of course they did. They didn't know how to deal with this psychological dependence. So this psychological dependence was a problem for the practitioner. They didn't know how to address it. And for the patient, they didn't know how to address it. So now one of our improvement strategies that Hannah and I are working on, we're in co-design workshops at the moment, and it will go out for field testing and then trialing, is techniques for practitioners to support this psychological dependence, and for our patients too, specific things that we know that will work. I'll tell you one other thing before I hand over to Hannah, and it's in green actually, this professional role and teamwork. So we started speaking to people in primary care where most of this goes on, and recently Hannah have done workshops and interviews with pharmacists, community pharmacists, with secondary care practitioners in A&E and acute assessment units, and with patients again, but this time we've asked patients about other care environments, not just primary care. And in terms of role, there's a real problem with role across the patch, not so much in primary care, it's their job to do it routinely. But then a patient will go into the ED and they're told, why haven't you got your blue one? You should have your blue one. Is your blue one? The hospital doctor's told them this, the GP's told them that, the hospital doctor is more senior and what patients' ways of thinking. So there's a real problem here for practitioners. Same with the community pharmacist, you know, their role is when a new medicine's prescribed, MART, rather than the 2 inhalers, to teach people. A lot of them don't know how to do inhaler technique or how to teach inhaler technique. So we're picking up lots and lots of problems that's getting in the way of this practice being done routinely, and we're at the stage now where we're starting to seek to resolve that. So this is improving practice, and this is what happens when we do it right, we make a change. Hannah.
Lovely. So I'm going to start with a really quick definition of PPIE, which is what I'm going to be talking to you about, because I think we have a tendency to use the acronym and assume that everyone knows what it means. And I made this mistake the other day and was speaking to someone who sort of understood it as a research methodology. So just to make sure that we're all on the same page, PPIE stands for patient and public involvement and engagement. And the underlying principle being that research isn't something we do to people or about people, but it's something that we do with and for them. So the idea of doing it with them, it means involving them in our research team. So the public are the people whose expertise you are drawing on. So for whatever research project you're doing, it's good to have a representative group of people on your team. The involvement is about having them as part of your team, so within the design and conduct of the activity that you're doing. And then the engagement part of that is about how you tell people strategically about your research, the outcomes, and why it's important, and what the implications of that are. It's different to participation, which is, as I'm sure you know, when people take part, they contribute their data that gets incorporated in the study results. So anyone in your PPI team are not participants within the study, just the same as any of your research colleagues are not contributing their data to the study. In the UK, a lot of PPIE has been driven by the NIHR, who set out clear principles for good involvement, things like being inclusive and accessible, valuing people's time and expertise, building relationships built on trust and respect, and making sure involvement is actually meaningful, so people can see how their input leads to change, rather than it being a tick box exercise, because that is frustrating for everybody. And I think you really have to commit to that, to those principles, if you're going to get the most out of PPIE. And if you do it really well, it can really take your project to the next level. So I'm going to talk to you about a project now where I use PPIE and how it really made an impact to the study. It really changed it. So this project was about the DLD, so developmental language disorder diagnosis, which is something that is a lifelong condition, but it's often diagnosed in childhood by a speech and language therapist who will communicate that diagnosis usually to a parent rather than the child themselves. So this project was about how that diagnosis is communicated and experienced by families when they get that diagnosis, because we understand that that can be quite difficult, and we want to be able to optimise that for families. So for this project, I wanted a steering group of parents who had real experience of navigating the DLD diagnosis with their children. So recruitment needed to be thoughtful and not just who happened to be in my inbox, because I know people who have children with DLD, but I really wanted people who were really going to be invested in this project and for whom this was meaningful. So actually recruiting people to PPIE groups can be quite challenging, so I wanted to be quite strategic with how I did that. So I reached out through a DLD charity who ran support groups, a DLD research newsletter that's accessed by families for updates, and a Facebook group for parents. I invited people who were interested in shaping a research project on the DLD diagnostic process. I think things at the time that were really key were that I was really clear from the start about what the PPIE role involved, the time commitment, and this was about improving the system and experience for families coming after them. One concern that I had for this particular group, and I got this from speaking to friends and SLTs who I know, was that I was worried that parents would get involved in the PPIE group thinking that being involved in research might help their child's language. So it was very important to be clear about the role and to allow them to drop out if they were no longer interested once they understood what that involved. So the PPIE group, they were involved right from the very start. So they were involved in planning the project and even finalising the research question. And this was really important, particularly for this group. One, because we know that research methods are not always accessible. So DLD actually has a genetic component. So often thinking about doing interviews are based very much on language. Would that be the most appropriate method to use with the parent group? Also, there's sometimes a disconnect between what's written in guidelines and what happens in clinics. So the steering group's role was really to help shape the research questions right from the start, the language that we use, and the way that the study was designed so that it accurately reflected family life and not just what's convenient from a research perspective. We could have the next slide, that's great. So we met regularly and they were treated very much as colleagues on the project. So they shaped the study right from the beginning. So they gave really strong feedback on the wording of interview questions, maybe if things felt confusing or a bit too clinical, and also what was missing from their perspective. So that led to us rewriting some of the topic guides over and over again to make sure that they were more sensitive, they were clear, and they were focused on the moments that really mattered to parents in that diagnostic process. they challenged my assumptions, and that was great. I was really pleased when they did that, when they were able to kind of push back with me, because that meant that, you know, we had a really good trusting relationship. There were times when I thought that a particular issue might be secondary, and the group said, actually, that bit is huge for us, that needs to come to the forefront. And this really influenced what we prioritised in the analysis and the themes that were drawn out as well. Really practical things were shaped by them, like how we handle consent, how we describe the project to families, and how we gave summaries to participants afterwards. One thing that we did, and you can see from the illustration on this slide, is that after we did interviews with all of our participants, we brought them back and we had a parent workshop to discuss what their priorities would be from the themes that were coming out of interviews. And they facilitated that workshop with me. And they also came up with the idea that it would be really nice to have that live illustrated. So we used some of our research funds to pay for an illustrator to be there, because it provided a really accessible summary of what the parents had been involved in, that they could take away and share with their children, their family, their schools, or anyone that they wanted to show that to, that would be much quicker as well than a research article, which can take a long time to produce and become available. So hopefully you can see that they weren't just an add-on at the end. Their fingerprints are all over the design and the data collection. And one of the most powerful points about this work has been what happened after we had all the data. So I made a very deliberate decision not to keep parents in the background while we went off to do the dissemination as a researcher, which is often the case with conferences. Every conference that I applied to, I asked, you know, can I co-present with a parent? Is there funding for that? Because I can get my travel expense, but is there a way that that can be done for the parents on my team? And every conference was very receptive to that. And we presented and shared the work together. So members of the steering group have joined me, not just at conferences, actually. They said they wanted to be on a podcast, and we actually did a Facebook Live, as you can see on the screen. That was quite brave for me to do. So we co-presented, and I would set the research context, and then they would speak directly about their experiences of being part of the project as a parent, but also the impact of the project. And yeah, really people found it very inspiring hearing from the parents directly, and they found that the data landed very differently. And I've seen the difference in the conversations that I'm having after we present. People are really excited to come up to us, and actually we presented at the Royal College's Speech and Language Therapist conference a couple of weeks ago, and the project won the conference prize. And I'm so sure that the parents in this group and their involvement had such a big contribution to that, and the way that that presentation landed. So I'm really quite passionate about how big an impact PPIE can have if it's done properly. And personally, standing next to them at a conference has been a real "this is why we do this" moment. It feels like a research project can be more like a shared piece of work when we do it with families.
Thanks, Hannah. Right, so in the last few minutes before we hand back to Alicia, it's to me to make sense of everything that we've said to you. So if you look at the research, you'll see these 5 main approaches to getting evidence into practice: improvement science, implementation science, knowledge mobilisation, co-working, and patient and public involvement and engagement. We've tried to give you examples of each of those so you can see how we do it. We've not given you any outcomes, but if you just Google Scholars, you can find some of our work and you'll see that it makes a difference. Being consciously aware of how we get evidence into practice rather than just telling people, giving them a guideline and expecting it will be done. So there's a couple of things that I want to say before I explain this messy picture. Co-working to us in this room, including Alicia, is absolutely something we would do on every single project. We wouldn't try and get evidence into practice without working with the people who are going to be delivering or accepting that evidence as part of their care and treatment. So this is an easy one. So every single time you're trying to improve practice, you're trying to implement something new, or you're trying to mobilise knowledge so that people can be healthier, so that practitioners can do things differently, I would say that you co-work. Now, I'm saying that in a really explicit way because we make that assumption. We wouldn't think of doing it another way, but when I work with other university teams, they don't do this automatically, and when they do it, I think they're doing something really special and really good. So I think what we would say to you is you always co-work when you're trying to get evidence into practice. Similarly, and I won't labour this point, but and Hannah gave a lovely example there, patient and public involvement and engagement. We would always have a member of the public who has got experience of whatever we're doing the research in as part of our team, and I don't mean as participant, just as Hannah said, but they will be a paid member of the team. Now, I'm also going to say that's not as easy as it sounds because we need money to do research, and to get money, we've got to put a funding application in, and a funding application requires time. So sometimes we're asking members of the public or our patients to donate their time before we get that money. When we've got a few kind of projects going as we have as a team, we can often borrow money from elsewhere to do that. But this can be really challenging to get a patient as a member of your team when you want to pay them and you haven't got that payment to make. But we would never conduct a research project, funded research project, without a patient as part of the team to give their different perspective on it. One of the things that I say as an implementation scientist, if there is one core skill or one core bit of what I do, it's about being a boundary spanner. And it's not usually the practitioners and the patients that argue when I get them in the same group. It's usually the different types of practitioners, oncologists and neurologists that hate each other. They don't all hate each other. They have very opposite views about prostate cancer. Same with obstetricians and neurologists when it comes to epilepsy in pregnant women. Very different points of view. You know, they're really seeing things from their own lens, as patients do. But often it's trying to help people understand the perspectives of each other. So that covers those two. These three then are very closely linked. They're all about getting the evidence into practice. The piece of work that's being illustrated here was when we got a lot of implementation, improvement and knowledge mobilisers together in workshops and said, what's the difference then? How do you do it? And what we found, if I was to put it really simply, is there is no difference. The same techniques we use for all three of these. Oftentimes, I call myself an implementation scientist. That's just because my PhD supervisors gave me that title, kind of, that's, you know, what I've adopted. But actually, if I call myself an improvement scientist, it would be the same largely. The differences that we did find, being really honest about this, were to do with knowledge mobilisation. And the difference there was spreading that knowledge much more widely. So almost leaning towards public health types of strategies rather than local strategies, or in-house strategies that we might apply internationally or we might apply nationally in specific environments. This was much more about spreading things far and wide, and often did involve public health types of campaigns, billboards, leaflets, distributing to everybody. When we looked at the literature to see how, when we asked people why we call these different, they all came from different places. So implementation, really, that label was born with the journal in 2005. Knowledge mobilisation was something it's been used in other fields, but in health that was it derived from an NIHR scheme. So they've all come from different places. I mean, improvement is as old as the hills. That comes from Schuhart and Deming, and it's really historic. Everything's been used somewhere before and been translated for this purpose. But those three things, the strategies we use, are very simple. If there is a principle to all of those, it is understand why people are not adopting the evidence into practice and solve that. And it could be because the patients don't want to do it, or it could be because they don't have time, which is not unsolvable, actually. We can make some things time neutral, but that's a whole different presentation. But these things are very simple and very similar, and the difference in terms comes from a tribalistic approach. Finally, then, before I hand back to Alicia, we did a literature review, sampled the literature to see how these interconnected, how people had used them, and lots and lots of time. And you can see there's arrows. People who use knowledge mobilisation also used implementation, and we're talking about nearly half of the time. There was a good use of co-working by lots of other groups, but not as much as you can see from these numbers, and so on. You don't need to know the numbers, you don't need to know the strength. We started with this thinking, how do these things interrelate? And we saw this mess and we thought, oh, please explain it. And we got into workshops and people said these things largely the same, we just call them different things. These two do it every time. Okay. On that note, then I'll hand back to Alicia and stop sharing.
Thank you so much for your presentations, Serena, Judith, and Hannah. I just want to ask if anyone's got any questions at all before I jump onto the feedback. No, okay. You're more than welcome to email me if you think of any questions, and I can email Judy, Serena, and Hannah anyway. I was just wondering if you could take your time now just to quickly feedback on this webinar. So if I share a form on Menti, you can either scan your phone on the QR or log into Menti and use the code and just answer these statements. So can everyone see the screen? Yeah. So do you agree with these statements? I found the webinar interesting. I recommend the webinar to a friend. I will use what I learned in this webinar going forward. So if people can just, thank you. And I've just got one more slide with another question on. Okay, so I'll just skip to the next slide. And then what did you think of today's webinar? And I think you can add 3 answers to that. And while you're doing that, I'll just carry on. So this is an ongoing engagement program for the Insights, and there is a timetable of events that are scheduled to take place. The next webinar is scheduled to take place early next year. I think that the next one is April. So you can visit the Insights website for the full program. And we will be also adding this webinar recording to the website too, so that if any people that did register but couldn't attend today's webinar, they can watch the recording back. So if that's okay with everyone and no further questions, I will end this webinar, and thank you so much for your time. And I hope to see you at the next webinar next year. Thank you.